Good evening. Julie and I have the pleasure to welcome you to this patient-centered webinar by ERN-RITA. So my name is Zoe Anastasa. I'm a patient having GPA vasculitis. I have been a patient advocate since 2019, and I am a patient advocate in ERN-RITA as well as my organization, Vasculitis International. Julie.
Hi, I'm Julie Power. I am a patient advocate just like Zoe. I also have vasculitis since 2005, so a long time patient. I am also in Vasculitis International, but my role in ERN-RITA is that I'm the vasculitis patient lead in ERN-RITA. So we'll carry on now, Zoe.
So today we will discuss the social rights of a person with a rare disease and the patient perspective in advocacy, the case of Malta. It is lovely to see people joining us across the world. We saw registrations from Egypt, Sweden, Portugal, Spain, France, United Kingdom, Ireland, Mexico, and many other countries. So some housekeeping rules. You are welcome to ask questions and make comments in the chat. Both presenters will take questions at the end of the webinar after both presentations have finished. We have decided to add a more interactive element to this webinar. We ask you to let us know through the chat if you would like to speak, and we will change the settings so you can speak through the webinar. The webinar will be recorded. I just say that so you know that if you speak, your voice will be recorded. And please bear with us. We have never tried this before, so things may go wrong, but yeah, we will try our best. Julie.
Okay, we only have 1 hour to cover this important area, and we have 2 presentations. So if you're asking questions or interacting, please keep to the subject. And in the interest of time and inclusivity, we may intervene. We mean no disrespect. If there are any unanswered questions in the chat, we will endeavour to pass them on to our speakers to reply. So with no further delay, I would like to present to you our first speaker, Sina Bugeja, who will talk to us about the patient's perspective on advocacy. Sina joins us from the Arthritis and Rheumatology Association in Malta. She is also the CEO of Special Projects in the Ministry of Energy and Health in Malta. So she will give us some key points of the EULAR Manifesto. Welcome, Sina. The floor is yours.
Thank you, Julie. Thank you, Zoe. And hello, Raquel. It's a pleasure for me to be here, and I will be sharing with you my screen so we can go through the presentation together. As has been discussed, we will leave the questions after the presentations. So basically, as I said, it's really a pleasure for me to be here, and I'm representing ARM from Malta. What I will be doing in this presentation is that I want us to together understand advocacy. Why do patients groups need to be involved? And then we will be looking at our own presentation that we have used in Malta about the EULAR Manifesto and how we have used it just before the MEP election that happened earlier this month. So if I look at a dictionary, at any dictionary, and I look at the definition of advocacy, I find that it is defined as any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on behalf of others. And I would like to change that slightly, and I would like to add argue on behalf of ourselves. As patient advocates, we speak for ourselves. And I think that is a very important point so that we are all very well involved in the whole approach. So why do we need to have patients groups involved? Well, I'm sure that people remember the campaigns by the gay community and the disability community, where they made this statement very famous: nothing about us without us. So I believe strongly that we have to be there and we have to put our views forward, because our voice and our experiences actually do matter. We're all empowered to take on the responsibility of helping ourselves and also seeking help of others. So we need to be really sensible and work together with the medical community and the scientific societies to take a message forward. And maybe this is the strength of EULAR. EULAR is composed of these three columns, these three segments, which are the scientific community, the healthcare professionals, and the PARE, which is the patient segment. And we work together, all three, in the interest of patients. So our message needs to be evidence-based. I mean, there is no way that we can influence changes if we don't use an evidence-based message. Whatever we talk about, whatever we say, has to be proven scientifically so we can really put it out there in a very strong manner. However, we need also to have a document that captures the message. And that document is what we will be using to put our message where it really, really matters. So we have to make sure that we know what we want, we know where we want to go, but we have it all written down, spelled out clearly so that we can really be effective. So if I use the EULAR manifesto preparations, the preparation started quite a few months early. I mean, you need time to write a proper document, proper research document with the experiences of patients, but also scientific evidence. So it has all been there. And the document states quite clearly what its scope is. So in any advocacy campaign that we want to be part of, we must make sure that we are very, very clear on what our scope is. If we get sidelined, we lose our impact. So the EULAR manifesto's scope was to put RMDs, because it's an active document, is to put RMDs on the agenda of the European Parliament. That is where we want our message to go. So our target were the MEP elections, which were happening across Europe this June, just a couple of weeks ago, resulting in new MEPs being elected. So there is a new cohort of individuals, and we want to make sure that they know about our problems, they know what they can do for us, we know what we are expecting of them, and we make sure that we take the message clearly to them without ignoring non-member states, because the representation in EULAR is not just member states, but there are also non-EU member states. So the document caters for both EU and non-EU. In any advocacy campaign, timing is crucial. I mean, we have been working on this document for months, but it was only released earlier this year, pushing it to reach a particular momentum around the MEP elections, because that was our target. So we must have good timing and a good plan, and a good plan that is agreed upon by everybody and taken forward, so it's, we can really make things happen. We have to make sure as well that we put forward a positive message. We are advocating on our own behalf, but the message has to be a positive one, because nobody likes negative messages. Research shows clearly that negative messages do not elicit the effect that one wants. If we go moaning to different organizations, to different groups, without really showing how what we want is going to change the quality of life, the message will not be bought. So we have to create a positive message, focusing clearly on how a better quality of life can actually be achieved. It has to be spelled out really very clearly. So we send out invitations and we start a discussion. But we also need to listen. We know what we want, but we need to understand that unless we listen to what issues the MEPs or whoever our target audience is, if we don't listen to issues that they put on the table and see how we can marry the two together so that it becomes one solid message, there is no way that we are going to be succeeding. So let's not assume that they know, because they do not know about the specific areas, the specific subjects. We are going to give them information on that. But we also listen to what they have to say. They have done good things, they have worked on other areas, so we have to be prepared to listen. We must indicate numbers if numbers will create an impact. In some rare conditions, it is not the number that makes the difference. It's really, highlighting the subject itself. Oops, sorry about that. Just a sec. Okay. So Oops, I don't know why I'm losing the screen. So the numbers have to be, if the numbers are going to be impactful, then we have to spell them out. And you will see in my presentation, we were talking of 120 million persons in the EU that are living with an RMD, and 120 million individuals is not a number to be ignored. So if numbers are going to be impactful, state the numbers. And give your supporters the available tools, the possibilities. We will be seeing in my presentation that we have highlighted already programs that exist within the EU, the Commission, that can give us the results that we want. So we're not asking them to create something from scratch. We're simply asking them to create the space for the RMDs to be able to be inserted there as well. And we need to show them clearly how they can help. This is not the only area they will be looking at, but we have to make it clear that this is how they can help. We have, we list things, we put things in perspective, we put them one after the other, and we show them how they can help us. And also what the benefits will be. What are the benefits that will emanate from these particular activities that we are asking them to do on our behalf? What is very valid for us to understand when discussing issues at such a high level at the European Parliament is that health is not a partisan issue. It catches everyone's attention across different political parties. So it's not about party A or party B. Health is everybody's concern. And we also encouraged intergroups between the parties, because if the subject can sit on both parties, then they can easily create inter-party groups, interest groups that can take the message forward, and then they can own the subject that they want to be working on. So what I will be doing now is I will be looking at our presentation, the presentation that we used for the EULAR manifesto, but I will not be stopping on every slide. There is a lot of information which may not be relevant here, but it will be available in the recording. But I will focus on the points where I want to highlight why our involvement in advocacy is of paramount importance. Now, what is important in this slide is the sentence in yellow saying promoting a European response to the public health and the socio-economic challenges. This is what we want to work on. The public health aspect and the socio-economic challenges. Of course, we're focusing on RMDs because that's the area I'm working in, but definitely when we speak of public health and socio-economic challenges, we are really touching the two main areas that will be affecting people living with certain conditions. This is what I explained to the MEPs. We want them to understand the current situation. We want them to see the European pictures, and we also want to put forward recommendations which they can act upon immediately. So the manifesto is looking at 120 million persons living with an RMD across Europe, and as I have already highlighted, this is not a number to reckon with. We really need to give it its due consideration. And then we're explaining a bit what RMDs actually are. So it's a long-term condition characterized by pain and high levels of disability and reduced life expectancy. This really had an impact because while everybody would know somebody who was suffering from some kind of an RMD, they were not connecting disability and reduced life expectancy. So sometimes the facts, put clearly on the table really gives an impact. But the next sentence is really what touched the policymakers mainly. Despite these numbers, people living with an RMD feel ignored by policymakers. And while it sounds like it's a very strong message, it is the truth, it's the reality. And it is the message that we wanted to put forward. We want to stop being ignored. We want to ensure that people living with an RMD are getting their due time and attention as well. So this is about how it is affecting. So I really don't want to go very much into this, but it's, we were looking at where the main effect of RMDs is felt. It's the workplace health problems, and it's the primary cause of work loss due to physical disability. So it's really quite seriously impacting the economy of the European Union. So putting the argument according to your audience will make the impact. for MEPs, we did not want to be discussing just the suffering of a person living with a condition. We want also to show that while people want to be economically independent, without their help to change certain things, they will be a burden on society. So, and this is not what we want. So we have highlighted this particular point so that they can see and understand what we're talking about. Again, I'm using the economic argument because that is the language of the politicians. And I mean, research has shown that €1 invested in research on RMDs delivers a return equivalent to around 25 cents every year forever. Now, this is really impactful. So investing in research and in treatment will give a solid return. And the burden of disease of RMDs in the EU member states is of 24 to 140 billion euros per annum, which equates to 2% of the EU's GDP. And these are the numbers that, you know, make all the difference for people to really understand. As I have highlighted, we have recommendations of what needs to be done, and I will not be going into any particular details here because I want to give the framework of how we worked on this particular campaign. And this slide shows what really emanates from the manifesto. It focuses on these three particular streams. So it's quality of care, it's the social policy aspect, and research and innovation. This is where the changes are, this is where we are seeking changes to happen. So when we're talking of quality of care, what we're saying is improving RMD prevention. We need to look at genetic and environmental aspects, early diagnosis, treatment and rehabilitation. And already, as I said, there are documents available. So there is Healthier Together, the NCD, the Non-Communicable Disease Initiative. Unfortunately, in this document, which carries quite a lot, a hefty sum of money, I'm looking at my notes to find the exact figure. It carries 156 million euros as a program. And in this non-communicable disease list, RMDs are not there. So this is what we want to see changing. So we have highlighted that particular point, but another point that is affecting the outcome of the patients, of the persons living with the condition, is the lack of professionals. We do not have enough rheumatologists, we do not have enough physiotherapists, we do not have specialized nurses, not enough, because there are a few, but not enough, and not enough occupational therapists and psychologists. So we have highlighted this, and we want to work together to promote, to create possibilities for people to seek these career paths and develop further, and then satisfy the need in this particular sector. So again, I mean, this is highlighting those same points, but I'm not going to go into any particular details here. Now, if we look at the social policy aspect, what we want to do here is mitigate the burden of RMDs on health-related quality of life, education, and employment. So we need to recognize our RMDs as a leading cause of disability. It is not given that perspective. We speak of disabilities across the EU, but we are not focusing on disabilities emanating out of these particular conditions. Okay, and we also want to ensure that there is proper provision for social care and mental health services. A person living with a chronic condition needs to have mental health support. And we are emphasizing these requirements and these needs so people can live as healthy a life as is possible. We want to have inclusive and flexible workplaces and openings in the education, and also what we call the accommodation that is required to facilitate the person can keep a job and be self-sufficient and be economically independent. And we want to see increased funding to improve mobility, access to buildings, and here I'm underlining, packaged pharmaceuticals and household products. Nobody is giving much attention to the fact that a person living with an RMD will have problems to handle, to open, to store packaged pharmaceuticals and household products. So we really want to be highlighting these particular points. The third point is the research and innovation, and this is where we really want to be pushing very, very strongly. We need to establish an ambitious and long-term research and innovation agenda. Without research, we are not going to change the situation. We know what the situation is now. We know the outcome. We know the treatment that is being carried, and we have made huge progress when it comes to treatment, but it is still not enough. We want to see funds being put very, very clearly into research and innovation. So as I said, we work with medical societies, patient associations, and the healthcare professionals themselves. And all the information is evidence-based. So there is nothing like I think or I believe. It's all facts written clearly, you know, where they can be verified. And there is a lot of research going on which confirms what we are saying. And we also need to encourage and support the involvement of patients, because as I said in my first slide, there is nothing about us without us. So that is where we want to put our emphasis. So we are also suggesting that we could launch an inflammation and non-communicable disease and comorbidities document partnership with Europe under Horizon Europe. Horizon Europe carries a budget of 95.5 billion. So the funds are there. We just need to make sure that we are included on the bandwagon and make sure that people living with RMDs are also given the same possibilities. This is the slide that I ended my presentation with. I said, you could be joining the ranks of the European policymakers as MEPs very soon, and we need you to be endorsing our efforts and to help us move things forward. There has already been one particular European Parliament interest group, which was led by the current president, Roberta Metsola, who is also a Maltese MEP, but it stopped when she started having higher positions. We want to ensure that such groups are there and moving things forward. 120 million persons living with an RMD are waiting. And if that is not an important message, I just don't know what is. So that was our presentation, and I can now stop here.
Thank you so much, Sina. This was very interesting, really. And as a patient, I cannot thank you enough for advocating what we all feel. And we all know that there's nothing more powerful than the patient's voice when you have data to support it. Exactly. We will come back to you with questions later. Thank you, attendees, for not starting asking questions already. But if you can prepare your questions to be ready for after the second presentation, I will be grateful. So let me welcome our next speaker. That's Raquel Castro, the Social Policy and Initiatives Director of EURORDIS. And she's going to give us a global approach to social right advocacy in rare diseases. Raquel, thank you for joining us today. The floor is yours.
Thank you. Could I just ask you to confirm that you see the screen?
Yeah.
Yeah, okay. I just need to, 1 second. So indeed, well, thank you for inviting me, and it's a pleasure to be here speaking with you, all the panelists and attendees. So I am not going to go into a specific example, which is why I think it's great to have the previous presentation first, because it's really concrete about a specific initiative that is in itself very comprehensive. In my case, I'm going to go over a little bit, maybe a bit of provocation around how we might be doing advocacy on social rights, seen from the perspective of our work and experience at EURORDIS. And for those of you who might not know, EURORDIS is the European Federation for Rare Diseases. So we have members from all across Europe and beyond, representing people with rare diseases of all sorts and from different countries. And so with that perspective, and also seeing that you who registered are from different countries and outside of Europe as well, and so you will have different social rights in possibilities within your country, sometimes even within your region or your city, and you will have potentially different names for the same things and different challenges, but there are some commonalities. So I will try, I believe, so I will try to focus a little bit on that and provoke us a little bit in our thinking about advocacy. So just about EURORDIS is that one very important thing about our vision is that we really hope people with the rare disease can have longer lives, but also better lives, and really achieve their full potential, which is really where the social rights also come in. And so it's not just about, or it's about everything. And it's about being recognized as equal citizens. It's about being supported with the different kinds of care and support that are needed, but also participating in society in all aspects of life, and having an independent life, which the previous speaker has alluded to, Sina has alluded to. And we do have a position paper at EURORDIS, which was built with this big membership across EURORDIS a few years ago, which is focused on what we named it at the time as holistic care. So really taking the 360 perspective of our lives as people with a rare disease, but also of the family members who are often also facing the impacts. And by 2030 was our vision. And that paper, just to give us a framework of how we positioned it, is that we had 3 pillars, or we still have, because there's a lot of work to be done. One, focusing on quality and adequate social services and policies, so more specifically on the social service and social policy side. One, extremely important, I'm sure you would agree, on integrated care, so really on bridging health and social care, ensuring that that link works, which you will tell me how is it working in your situations. And then the pillar 3, which is on equal rights and opportunities. And that's where we dig a bit deeper into issues as disability and independent living, which Sina has alluded to as well, employment, which I see is very important for potentially for those of you attending, and also around other areas where there might be discrimination. And so that really guides our advocacy in terms of the spirit behind the needs that are there and what we want to achieve. Then, of course, we have to work on specific areas where there are opportunities in terms of advocacy. And as EURORDIS, we look specifically into European advocacy opportunities, so potential legislative proposals at European level or other initiatives at the European level. And we work with our members, for example, the alliances at national level, to support them in national policy where possible, knowing that we ourselves are not experts in national policy, but of course the alliances follow it very closely. So the first provocation I would like to do is that saying here that social rights is not business as usual. I think nothing is business as usual for our community. There's no such thing. But what I mean here is that we have a certain way, I think, traditionally within the community, and of course there might be variations within the organizations you know or the people you know, but a lot of our time has been spent in advocacy around the prevention, early diagnosis, or diagnosis at all, treatment, and the healthcare aspects. And primarily along the years we were very strong in that, and we have a very strong argument, certainly, and we start to have evidence now despite the rarity of the conditions, and we are used to working. And I was listening to Sina and taking notes and saying, indeed, we are used to talking a lot about evidence and talking a lot about science, and that's served us in our advocacy there. And in social rights, sometimes things are a little bit different. So the first thing it hadn't been years that I didn't use this slide, but it used to be very successful, so I brought it back. But the first thing we realized over 10 years ago at EURORDIS, when we started to try to work more on social rights, the first thing we noticed is that a lot of the things that were going wrong on the social side, something had to do with the healthcare side. But also we realized that when we were going to healthcare and we talked about a social problem, we were sent to the social services or social welfare system, which makes sense. But then when we would get there and we would say we have a rare disease, well, no one knows what it is and what happens when living without rare disease. So we kind of ended up being thrown back to healthcare, and then we go back and forth and try to make something happen for our quality of life and our life in general to improve. And this is obviously a big problem, and that's why I think the pillar 2 on integrated care is huge, and there is certainly a role for ERNs there. And in the new ERN joint action, the European joint action, there will be some work on some aspects related to this integration of care, case management, and so that's really good that it's there and that the ERNs have a role there. But it is a problem that is there. And the other thing is that these sectors tend to work in many countries. They are separate authorities. They are managed by separate authorities with separate budgets. In some countries, it's not the case, but in many countries, they will be separate, which makes it harder to get policies going that actually serve us fully in our 360 degrees. And so with everything going on, and this is an image from Sweden, not from us, with everything going on, we are often a bit lost or overwhelmed with all the things that we have to do, all the professionals that we have to see. And actually, EURORDIS ran a survey in 2017 where we could see with over 3,000 respondents across rare diseases and across Europe. And we could see that the evidence for the big issues around care and care coordination. So visiting a high number of professionals across health, social, and local services, feeling that the services communicate badly. So that was 67%. So obviously it's the feeling of people, but it's your experience, the experience of people who are living with a rare disease. Also, 7 in 10 did not feel they were well informed about their rights in general, so irrespective of whether they were healthcare rights, social rights. And 7 in 10 found that organizing care was time consuming, while 6 in 10 found it hard to manage, which is unsurprisingly, I suppose, to all of us here. Unsurprising, but it is good evidence to have, and we use it consistently in our advocacy around integrated care. The other aspect I wanted to really tease us all about is this medical model and social model. And Sina was saying in the disability community, there is this slogan, nothing about us without us. And I think we can learn a lot from the disability community at the same time as we can share a lot with the disability community. But the first point I want to make is the disability community is us too, because we will go to that later. But as far as we can tell, and we are going to run a new survey now, which I'm going to tell you about also, most people with rare disease live with disabilities, some sort or several disabilities. And so that means that we are a part of this community. There are many other people with disabilities who are not living with rare diseases, but most people with rare diseases are living with disability. So obviously there's a lot of work we can do on social rights with the broader disability community. And that is going to be, I believe, very helpful in getting what we need. But there is one thing historically that has somehow, that's why we said the disability community, the rare disease community, disability advocates or activists, rare disease advocates. There's been something there which is still talked about, which is this issue of the medical model and the social model. So the way we see ourselves and we perceive ourselves in the rare disease community, we tend to focus a little bit more on our medical conditions and to focus a little bit more on how those conditions disable our life, how they make us disabled. So we might focus a little bit more on the functionality. Here there's an example of seeing or hearing, but in the case of our audience here, it might be your fatigue, or it might be other symptoms, other situations that are even sometimes invisible, or when you have flare-ups, for example, which even vary. So we might tend to focus a little bit on that and how our body is somehow not functioning as it should. And we focus part of our work on trying to fix that, on trying to find treatments and the right care that helps us to potentially cure that, or reduce significantly how our body is, those functionality issues. And on the other hand, the disability community tends to talk more about the social model, which does not really ignore that, but rather than focusing on that, also considers that there is an environment in which we are, and that environment is not really accessible and is not really eliminating, it's creating a lot of barriers for us to be able to live an independent life and to have our human rights respected, even with our disease. So this has, in social advocacy, this becomes quite important, because when we go to welfare authorities or public servants working in healthcare authorities or policymakers who are more working on welfare policies, they don't necessarily see us as patients. And if they do, they might discard some of our needs, thinking, well, maybe healthcare should take care of that. It shouldn't be in our budget. Because when we talk about employment and when we talk about school, for example, in the case of children, or when we talk about other social situations, we are not really patients in those situations. We are people. But of course, when we are attending to the hospital, getting a diagnosis, we are patients in that setting. So it's a bit, sometimes we discuss this at EURORDIS with different members and we say, but then how do we, what do we do? How do we talk about this in our advocacy? And lately we have been discussing this approach that, well, it's all human rights, right? If we're fighting for diagnosis, for treatment, for prevention, those are rights that we have. And if we're fighting for our social rights, those are our rights too. And so we are full people, and we are not just a patient in this setting and then nothing else. Everything is happening around our lives. And so that's where more recently there's been in advocacy, in the disability movement, there's been this what is called the human rights model. It's basically just going further a little bit and saying there's not only the barriers, and society is not really providing the accessibility, the support for our needs, but also that there should not be any excuses, because there are different human rights. Employment there are different rights that we have to school, employment, social participation, and there's no excuse to be denying those access to those equal opportunities. And of course, there's a long way to go, and we cannot just go and do things like that. But I find that these are important, in our experience, these are important perspectives to consider when we start working more in advocacy, and even when you are advocating for yourself, so that when you are going to a certain setting, you might be tempted to talk a lot about your disease and your function, but don't be afraid of talking about what society is not providing, the accessibility issues that you're finding, the lack of workplace accommodation, the support that you're not finding, and the needs that you have, whether they are connected to your disease or not, or not directly, because sometimes there is something that comes from the disease, and sometimes there is the impact of that in your life. So you might not need to be on sick leave, for example, because of the condition at a certain moment, but you might be actually attending a series of physiotherapy, different things that impair your capacity to be at work full time, for example. And so there's a number of issues, and what we say does matter. So I would encourage you to think sometimes to refer to yourself as a person rather than a patient. It's just language, but it does tend to, in our experience, at least for those of you who work in advocacy with policymakers at national level or even at European level, if you are part of the European Federation, those are different conversations that we have when we are in social meetings and when we are in health meetings. And the language is quite different, and we are certainly more heard when we speak the language of those stakeholders. But also we do have we can also educate the other politicians. So Sina said that we use the language of politicians, and for example, on demonstrating the burden on society, and that's important and it works. At the same time, we also can, well, try to raise the awareness of policymakers to other issues, or in other ways to say that it's not necessarily just about burden. It's about fully participating in society. It's about being full citizens who also will vote for you and elect you, and who will participate in our democracies, in our societies, and be active in different ways, and therefore have less economic, socioeconomic barriers, etc. And I believe we have, in many years, we will have an impact also in that message when we educate that. So we use increasingly more at EURORDIS concepts like participation in society, holistic care and support. So it's also good not always to focus on care. Not everything we need is care. For example, in employment, it might be workplace accommodations. We might just need to adapt our schedules, or we might need further support, and maybe we need some part-time work, part-time pension, or different situations, but some of them are not care. So it's important to refer to broader concepts. And in disability, it's important to also think that it's not just about our body, how our body functions. It's about what's around us. And of course, two people, and that's the issue with evidence. So when you are collecting evidence within your respective disease communities, if you do, or when you're bringing your own case and thinking, okay, what's not functioning properly with my body, also think about, of course, what is the environment I'm in, and what's the impact for me. And maybe two different people with the same seemingly functional issues will have different disabilities because of the setting where they are, and maybe because of the conditions of their housing and how they have to access their house and get out, or the employment, or the type of employment they have. And this is not connected to the body itself. It's really connected to the environment. And so that's why sometimes the same collecting evidence on functionality alone or sharing that evidence can be a little bit misleading, sometimes in advocating for collective rights or for individual rights, if we disregard the environment. And we need a system which is not there yet in most countries, but actually Malta is apparently working on a reform to make it better. We need systems that are able to assess these individual needs, and that are needs based, and not just with a checklist of imagining for your condition that you would have for a primary immunodeficiency. You would have a list. Okay, this is what happens with these people. You go through the list, you check, and you send the person away. We need a system that has to, and we need to advocate for that, a system that really considers the needs of that specific person, being informed by what is the situation, of course, that condition might generate. And of course, it's really important what the person wants, what the family wants, and that might be different from what others think they want. So that's also really important for us to keep in mind in our work and in our own advocacy. Now, one thing we've realized, and here I will not go into too much detail, but just to leave it here for you, is that things that we are advocating on because we think they will make big changes are this issue of integrated care pathways, which I mentioned before, having person-centered and lifelong care and support plan somehow. And of course, the challenges to these are enormous. Who has that plan? Where is that coordinated from? And so big issues to resolve. One of the solutions we've promoted widely and will continue is case management for people with rare diseases, and there's different ways in which it could be organized. There are some examples ongoing. There's also resource centers, and if you would like to get more information after, please do get in touch. There are a few services in Europe that are not really healthcare services. They are some kind of mix between health and social, and they provide different resources, training, family weekends, and different solutions to families that are quite supportive. And a key issue is with this disability assessment. I will talk a little bit more about that. And of course, training of professionals is essential, whether they are healthcare or social professionals. So why disability and independent living? I already said that most of it. So just to say that really, when you think about disability, think broadly about the different impairments, but also the interaction with the barriers. So the interaction with the environment around you and the barriers that might hinder your participation on equal basis with others. And so they can be visible, invisible, degenerative, or vary over time, which I suspect for several of you, invisibility might be a big issue, and also variation over time. And these are not often recognized by the services or the authorities that in order to provide you with the support that you need or with the workplace adaptations that you need. And as I said, let's remember that we are a part of the disability community. So we can advocate for our disability rights, of course, and disability assessment is the first step. If we do not get our disabilities properly assessed and properly recognized, we often do not get the adequate social protection that depends on that process, which is quite a good part of it. And we might struggle having independent living support, at least that provided by the public systems. So for us, this is a huge advocacy priority on which we are working in different ways at European level, which I can provide you more detail after. But it's really essential to us because, and especially well, one of the groups being people with invisible disabilities, with rare diseases and invisible disabilities, because we know or we suspect that those of you who have them are facing quite some challenges with disability assessment, and the rights you can access based on these processes vary from country to country, but they are quite extensive, and they're not just mobility aids, for example, right? There's a lot of the social rights which are associated to that. So to finalize, I wanted to tell you that we are launching a survey on the 10th of July, so very, very soon, precisely on the impact of living with a rare disease on social participation, so school, employment. So it will be filtered. So if you were answering on behalf of a child with a rare disease, you will find more questions on school. If you are answering as an adult or on behalf of an adult, you will find more on employment and other, and someone on school still, but thinking of adults or young adults. And there are also questions on independent living. And our goal is really to identify the barriers to participating in different activities such as school or work or leisure, and also the needs regarding independent living. And what do we mean by that? For example, the housing situation, personal assistance situation. And I don't know how that might be a big need or not within the community here. So different rights around living your life as to your full potential as independently as possible. And we also want to collect experiences with disability assessment, because our previous survey had an hint into this being going. More than half of the people are facing challenges, but we didn't ask what the challenges were. So now we are asking more about that and the bigger barriers and facilitators in accessing social and disability rights. So we really hope to use that in our advocacy. But also, it's not just for us. I will tell you how the ERN, for example, can access. So we're launching on the 10th of July. It's open to anyone living with a rare disease anywhere in the world. It's available in 25 languages, and it will close on the 8th of September, so roughly 2 months after. And we should have results towards the end of the year. We do publish results in different ways, including a report and fact sheets, but we also have dashboards, which in fact you can, so for example, the ERN-RITA can request access to the dashboard once the list of diseases has been validated. And so then to see the results for the group of conditions, the respondents who are part of live with these conditions that are covered by the ERN. And this can be used in different ways within the ERN, but also if you're part of an alliance at national level or an European federation, they can also ask the results, the global results, and then the national results specifically for the alliance, and the disease results for the federation. So this is that in a way EURORDIS will use the results, but the results are also made available so that other organizations can use them, these other organizations, and in this case the ERN. And this might help you all plan some future advocacy as well. We have a launch webinar coming up on the 10th of July. I will leave you the link here on the presentation if you would like to register and know more about the survey and how you can take part and how you can share it. But if you also want to just, you think you would like to answer the survey, but you will forget about it, then I will leave you the link here where you can actually register for our panel, for our survey panel as a respondent. And once the survey is going, actually you will get it before the 10th of July, you will be the first ones to get the link to fill in the survey. And so you will get it in your, once you register here, you get it in your email and you don't need to think anymore, when is the survey coming out and where can I find it? So thank you very much. I will try to come back and stop here. Thank you very much.
Thank you, Raquel. That kind of a whirlwind tour there. I think, you know, there's one in 17 of us living with a rare disease, you know, so that means there's an awful lot of us out there. And I think one of the statistics you gave there, 7 in 10 are not well informed about their rights. That's pretty frightening, I think. And that, you know, like the healthcare information and the social care information, that it's all in silos, you know, like we really do need to start getting integration there. So we have 5 minutes left. I believe there are 2 questions. Do we want people to join the panel here so that they can ask the question? I think
Shall I read the question we have already? So we have a question to Sina. With your expertise, how do you recommend to advocate for children and people with mental disabilities? It comes from Geordie Anton.
Okay, it's not an easy question in the sense that we need to know exactly what we want to achieve, because unless we have a clear picture of what we are aiming at, then we will have a lot of waffle and not being too focused. We need to be focused. We need to understand clearly. So I think we need to be specific and advocate on a specific approach so we know exactly what we want to achieve, so we can work on that. I mean, I have seen a number of advocacy campaigns in the past which are generic in their approach, and then the result is a generic one. It is not a specific one. So we might need to start off from a generic base, but then we need to be focused whichever way we want to go. And advocacy, and we need to understand as well that an advocacy campaign does not have to have a linear approach. There can be times when we need to go off in a tangent to focus on a specific issue, and then we can ensure that those requirements are being spelled out clearly and working with the people who can make a real difference.
Okay. We have a question for Raquel. There are a huge lack of patient involvement for some diseases or in some countries. Which are your advices for those patients or members of small patient associations, how they can enrol, learn and support?
Very, very good question, very difficult one. I think there's a number of ways, certainly, in which you can get involved. It's understandable that there are many reasons why people might not be engaging, not just the low number of people, but also the way that their daily life is somehow not allowing them to spend time or energy on that. And so we do tend to have a certain number of people who engage more in organizations at national level, even less at European level, also because of language barriers and other barriers. So it's something that does happen, but there are different ways for those who want to get involved, and their organizations are just smaller. So my advice would be, of course, to reach out to the bigger organizations in your country. Sometimes they have working groups or different ways in which you might be able to participate and contribute to advocacy they are already doing. So rather than trying to do your own advocacy, you join forces, for example, with a national alliance or with a federation at national level that might have different conditions, including yours, or that might be open to include your condition because you have similar challenges. So I think that's quite important there, is to align forces with the already existing associations. We are not that big in numbers individually, but collectively we are, as Julie was saying. So that's really important. And also, especially in social rights, it's really important to unite, because when we are advocating for, even though it is specific and you might achieve something, when you are advocating for social rights for a specific condition, sometimes it's quite hard to get that to pass. And when it passes, we could ask ourselves globally whether that's really fair towards on a societal level towards others. So for example, I come from Portugal, and in Portugal there are some specific policies for specific diseases. And of course, other groups have been for years trying to fight for example, early retirement that has been validated for certain conditions, but not others. And when we think we have 6,000 rare conditions, of course, we can think about ourselves individually, but we are so many, and within this ERN, there are so many conditions that if we fight for the rights of each individually, it will go very slow. It will be a very hard process. And with time, we are kind of overwhelming the policymakers with whom we are engaging. And so we might be wearing out the responses over time. So really, for me, it's align forces. The other thing is there are resources online. If you speak English, etc., EURORDIS has a training platform, the Open Academy. There might be some resources there that are useful for you. Beacon as well, in the UK, has different resources, and several organizations have done trainings and different resources that might help you get started on some advocacy. And so we can share some resources after on that if it's useful. And could I react just on the point of children with, just to say one thing? I suppose you're referring to intellectual disabilities and so cognitive issues that affect cognition and potentially also communication. I think the only risk on advocating for those children, which we sometimes forget if we are parents and family members, is that sometimes we have a hard time to communicate with those children and we don't necessarily know what they want. We know what we want as families. But so it's important to, I think the first steps is also to, and sometimes it's extremely challenging to try to understand what accessibility is there to be able to communicate. And as a family, sometimes you know exactly how to communicate with your child in their way, but also you have your own wishes too and expectations, regardless of them having a disease or not. That's what happens between generations. And it's important to consider that when we are doing advocacy on behalf of children.
Maybe just one point I wanted to add to that is that if it's rights-based, then we will eliminate this sort of transition that we need between child and parent. If we're advocating for rights, then it's everybody's rights, and then those who pick on them will pick on them, and those who don't just don't. But there will be a standard platform from where we can start moving.
I think this has been a really, really interesting discussion. I nearly wish that we had more time to delve into things more deeply. And I think maybe there might be a possibility that we should do something like that in one of our future webinars. I'd like to thank the speakers very much for their time, and to the audience for coming along this evening, and my co-chair Zoe, and Colleen and Camille in the background. And we'll just wish everybody a really nice evening. There's another other question in the chat, and I think we will try and address that offline. Okay, good evening everybody, and thank you very much.
Thank you. It was a pleasure.
Bye.
Thank you. Bye-bye.